Welcome, everybody. If you are joining, if you could just put in your name, your organization, and your pronouns in the chat, that would be awesome. We will get started in just a few moments.
Okay, well, we can get started. Thanks everyone for joining today. As usual, brief housekeeping. If you didn't hear this before, please put your name, pronouns, and organization in the chat. Also, of course, these slides will be shared after the presentation, and a recording of this will be shared after the presentation. So no need to worry about that. We'll send you the slides. And lastly, of course, please stay on mute if you're not talking, but feel free to come off mute at any time to ask questions, or you can pop the questions in the chat and we will make sure that Sarah sees them or hears them, because it's hard to see the chat if you're sharing your screen. And without further ado, we can get started. Our speaker today, we're excited to have Sarah Ryder. She's a psychiatric nurse practitioner at the Department of Psychiatry at University of Colorado Anschutz Medical Campus. And she's going to talk to us today about the importance of language and our choices in language when we're talking about substance use. So take it away, Sarah.
Great, thanks, Katie. Let's see. So the goals of this, I've done this presentation a few times, and the first time I did it actually was for RNs when I was working as an RN on the unit. I work at CEDAR, which is the addiction treatment facility that's part of UC Health. We do inpatient and outpatient treatment. So I'm excited to present to a group of what I understand is mostly RN. So the focus of this presentation really is on practical tools that you can take away to help improve documentation, to help improve interactions with patients. And one way to do that is through the use of terminology and language. There on the right is my son, Isaac. This is when he was about 8 years old. He was diagnosed with type 1 diabetes. He's 17 now. And his way of coping with his disease was to be completely out and proud. And he wears his pump on the outside of his clothing. He likes to show his continuous glucose monitor. And it was a way of sort of taking back his power. I know a lot of other kids with diabetes do not respond the same way, that they don't want to have a pump because it's awkward and it's different. And this is from the recent Pixar movie Seeing Red, which had representation of a character with type 1 diabetes. And it's the first time in an animated movie that type 1 diabetes has been represented. And the diabetes community went crazy. Like, this is all over the place. So I became interested in this through diabetes, where we had some training as parents with the Barbara Davis Center about how to talk to our kids in a way that was respectful and in a way that was really accurate. For instance, good and bad blood sugar is a pretty common way to say, like, is your blood sugar good? Is your blood sugar bad? Versus your blood sugar is not in range, or your blood sugar is 320. And that made me think more and more about how in substance use treatment, we talk about treatment, we talk about the disease, and we talk about recovery. And so I started to just pay attention more and do some more research, and really started to notice in clinical documentation, especially now that patients can read our notes, including psychiatric notes. And so I'm more and more passionate about this as things change. And this slide, I pulled this. This is David Sheff, whose son Nick has been coping with substance use since he was 14 or 15 years old. And the difference between what David and his son have experienced in healthcare versus what Isaac and I have experienced, it's pretty stark in terms of access to resources. So when I started researching this work, the real work on stigma in healthcare came up, and Lincoln Phelan were always mentioned. And so they're sociologists, and in 1995, they developed a theory about how socioeconomic status impacts health outcomes. And that research had been around for a while, but they broadened the term socioeconomic to mean education, power, social connections, status, all things that impact stigma. And regardless of what the disease is, whether it's type 1 diabetes or it's opioid use disorder, stigma impacts people psychologically in the same way. It impacts systems in the same way. And one example of this that I think is particularly stark is that we put a lot of money towards research for cardiovascular diseases. And one of the reasons for that is because men tend to have higher rates of cardiovascular disease. And initially that it was because men were in power in medicine, and that's where the agenda was driven. So a lot of these power structures are really impacting substance use right now. And we've seen this with opioid use in particular, where opioid use has really gotten a lot more attention because it has it crossed demographic areas in a way that other substance use has supposedly not. Although it's not true, that's the media portrayal of it anyway. And this model really can be used for any disease, and has endured all these years. So one of the things that really factors into stigma and judgment are these really three components. The big one is cause. And so with substance use, this is fairly obvious. There's a lot of it's their fault. As opposed to type 1 diabetes, where there's a level of, oh, this poor kid, it came out of nowhere and he couldn't help it, versus substance use disorders. And the saying in treatment is, no one's going to bring you a casserole, because people don't think you're actually sick. And you're expected to kind of pull yourself up on your own. And then control obviously also plays into that. The portrayal of people who use substances as being completely out of control, which is ironic in Elias, and I talk to patients about this, as substance use is a compulsive disorder that involves a lot of control over the use of the substance itself. It's predictable. Even in chaos, and it's a misnomer that these are wild, out of control people. And then treatability. There are not a lot of portrayals of recovery in the media. There's a lot of sensationalized portrayals of substance use itself, recovery not so much. The Hulu special Dope Sick, which is based on a book by Beth Macy, I think has some really great portrayals of recovery. And it's one of the first times I've seen that. And I've talked to a lot of my patients about it, and they're over the moon about how opioid use was portrayed in that movie. So stigma, it bridges a variety of domains. One of the domains is community, where there are stereotypes perpetuated and leads to a sense of rejection, a sense of being an outcast. And this is true for things like employment, where there's, depending on the organization, there's rigid drug testing, there's, having to disclose what medications you're on and things like that. I talked to a patient recently who said, I just want to be looked at as normal. And that has made him feel like he will never fit in, like his recovery is never going to be good enough. And then systems, of course, particularly, the legal and healthcare system. Substance use has traditionally been looked at as a legal issue that has been superimposed on a public health issue. And so those things have gotten muddied in things like the drug war, which in a lot of ways is less a war on drugs and more a war on the people who use drugs. Although I think that's slowly shifting. And then within the healthcare system, access to services for people who use substances is definitely not equitable. And there's, been policy changes along the way. The Mental Health Parity Act is one. Medicaid recently expanded payment for residential services, but that's been a long time coming. And then personal, so that's the internalized shame of using substances. It's the self-stigma, we often refer to that too. And it was interesting because I talked to a longtime patient of mine yesterday who was talking particularly about this. She had recently gotten some dental work and had a really good experience with this particular dentist. And I supported her, through pain management options. And prior to that, she had been to a dentist in Indiana who basically said, you're going to have to stop taking Suboxone, or you're just going to have to suck it up. But pain never killed anyone. And she delayed getting dental work for like another 5 years because she felt so much shame around that. And it was a really, stark example of how we respond in healthcare. There's research that shows that healthcare workers have more fear of people in substance use than any other patient population, meaning that they're concerned about their reactions. They're concerned that they're going to be violent. Again, this goes back to the legal and criminal justice issues around substance use. And healthcare professionals spend less time with patients who have substance use disorders. And when I read that, I could see it in my own nursing history. It's generally like people, that's the last patient that people want to meet with. I've talked to friends who are in school for counseling, and I want to do everything but substance use. I'm like, well, I hate to tell you, but I don't think that's possible if you're going to be a social worker. And then a big one is medications. And fortunately, I think this is shifting a lot. When I started working in substance use treatment almost 8-9 years ago, there was a lot of shame and stigma around medications for opioid use. Methadone, certainly, but also buprenorphine. And this has crashed head to head with 12-step programs in a lot of ways, where there's sort of this built-in belief system or implicit judgment that medication is only an adjunct to actual treatment, which is, doing 12-step work, doing counseling, those sorts of things. So that has been, a big part of why I've been interested in the use of language in substance use treatment, because the term medication assisted treatment, I think is starting to be phased out, because we don't say insulin assisted treatment. We don't say, counseling assisted treatment. There's a great research article called "Just Call It Treatment," and that's what I'm constantly saying to people: is just call it treatment. It's all equal. And in fact, medications for opioid use disorder have better outcomes than other psychosocial interventions. So we, in our use of language, can really be subversive in terms of changing the dynamic that we have with our patients, in terms of modeling the way we interact with patients to other healthcare professionals, to family members, and to patients themselves. And patients have pointed this out to me about, the way I talk about substance use is different. And they've started to talk about it differently when they're talking about their recovery. So where language can seem like, it's not that big of a thing, the research it says otherwise. So this, most people probably have seen this. This is the, I think, really incredible health department campaign, lifting the label. And it was really about dismantling the stigma. And it was, a campaign that sparked campaigns across the country. I mean, if you look up stigma and substance use, there are many campaigns like this now, where it's individuals who are in recovery basically outing themselves, saying, look, I'm just like everyone else. And I think it was incredibly impactful. So talking about guidelines, I want to be sure to really be clear that language is dynamic. It's changing all the time. I think the way we're talking about gender now is indicative of that. And this is not something that we're going to get perfectly. It's an evolution. And I think we can start to develop the self-shame around not doing it right. I was talking to the psych NP that I work with yesterday, and she said, "Oh, you're doing your presentation tomorrow. I keep reminding myself not to say MAT, and I feel so bad about it." I said, "Hey, it's learning a new language, really. So it's bringing it to consciousness." So these are really the touch points, especially for healthcare. There are many other ways around this, but the big one is presenting substance use as a chronic health condition. And I'm sure you all have had, robust education on the neurobiology of substance use disorders. And it's medical terminology for medical settings. So if I'm talking casually to, a friend in recovery, they might use different terminology than I'm using when I'm documenting or I'm using in clinical settings. And that's, again, the language is dynamic. And then as part of this, conveying that it's a treatable condition. It instills confidence in patients, and the research has shown that when substance use disorders are presented as a treatable condition, it's motivating. One of the reasons people often don't seek treatment is because they hear the rhetoric that once an addict, always an addict. treatment doesn't work. Only inpatient treatment works. And so, conveying that there are different pathways to treatment, conveying that there's a continuum of care, and conveying that it's a chronic disease that requires different levels of services. I often explain it, using this same medical model of when you have surgery, you might be in the hospital for a few days, and then you step down and you're in PT, step down unit, and then you go home and you have restrictions, and then for the next year you have less restriction, and so on. And that really resonates with people of, oh, okay, it's just like any other chronic condition. And then person first language. And so this was when the American Diabetes Association and the American Association of Diabetes Educators came out with their guidelines. This was number one, as referring to people using person first language versus he's a diabetic, he's an alcoholic, because it's demonstrating that the person is not defined by their condition. They're not defined by their behavior. And this is more and more true across the healthcare system and in the disability community. So strengths-based, this is common in any sort of counseling model, is to use strength-based language. I think it's extra important in substance use, because again, of the self stigma, because of the messages that people have gotten. It's I think just more important to really go from a strengths-based foundation. And then use language that's consistent with how the person identifies. I had someone recently tell me that they don't identify as someone in recovery, and they don't like that language because recovery to them means recovering something that they lost, and they'd had so many traumatic experiences that they didn't want to recover that life. They wanted to move forward. And so they identified as a person who doesn't use substances. And I stopped using the term recovery. And I thought it was interesting because recovery is usually a positive term, but not necessarily for everyone. And I pulled this picture because, again, I think it was a really positive portrayal of people in recovery. I mean, it's showing connection, it's showing happiness, and we need more and more of that. So I wanted to give you some real world examples of documentation and how it corresponds to those guidelines. And this definitely, depends on what situation you're in. Sorry, my screen. So chronic health condition, the rule of thumb for me, and when I talk to students about this or coworkers, is just keep it as boring as possible. One of the things that I see all the time is how sensationalized substance use is. So just keeping it as, I say drama-free, and thinking about like, if this patient reads their chart, what are they going to see? So I tend to use a lot of quotes. I use a lot of, terms that the patients are using themselves in quotes, and then using all of my terminology based on the description of the disorder itself. So, patient describes, patient reports, we use this all the time. I'm even more conscious of it when I'm documenting for substance use. I'm not saying this, I'm not saying, this is what's going on, the patient is saying this. This would be, in a situation where I'm doing an HPI. And for treatable, I say this almost every day to someone is, I don't really know what you've been through, or I can see your experiences have been really difficult. Let's work on this together to find out what's going to help. And often that's identifying like, what do you have going on that's working? let's start there rather than starting with the pathology, starting with the problem. And patients will say, I've never had someone like approach it from that angle. It's usually like, what do we need to stop and get rid of, especially in abstinence only services, rather than like, okay, how can we build on what we have already? And then person first, self-explanatory. And then, the strengths base again, identifying in the beginning of the conversation what is going well. So maybe someone is still using opioids and has not met their goal, but they've really decreased their cannabis use. So I'll start with that and then talk about the other opioid use. I can see you're a very resourceful person is something that I say a lot. And in your setting, saying something like, I can see you really want to be a good parent. I can see you really want to be successful. How can I support you? So this is kind of a cheat sheet I made. We often call it an addictionary, and I made my own. And just going through it again, it has a substance use disorder, person who uses substance, person who injects drugs. This is one I see often in ER notes where it says injection drug user. And I've had patients say that is their heart just sinks when they read that. And then medication assisted treatment, or replacement therapy or substitution therapy. Medications for substance use treatment, pharmacotherapy, opioid agonist therapy, and then the addiction medicine, really medications for addiction treatment can replace MAT. I think it's going to be challenging to switch that term myself. And then clean, dirty, not using that for urine toxicology screening, or for injection equipment or equipment for using substances. It's sterile, it's unused, things like that. And then recurrence of use rather than relapse. And really this came from, we don't describe any other medical condition using the term relapse. We say they're in remission or symptoms have reappeared, symptomatic, asymptomatic. And I think that's really a big one for where I work and my team, trying not to use the word relapse, and it's challenging. And this is sort of extra credit language. It's especially the last few, where it's the perception of people with substance use disorders being resistant to treatment or non-compliant. It's patient declines, choosing not to, prefers not to, and then manipulative, trying to get their needs met, trying to survive. And I have patients all the time saying, oh, I was so manipulative when I was using it. I said, oh, it sounds like you were trying to survive. And modeling that again for our patients. So I wanted to leave with some of the pushback I've gotten from people I work with, from people in the community, is this is just another, cancel culture, politically correct. And the Associated Press a couple of years ago put out guidelines for how substance use should be written about. And I have noticed less and less the portrayal of substance use being addicts, junkies, kind of outcast of society. And so I was happy to see that. This slide was the exception. And I think with parenting and pregnancy, we're still a little bit behind on that. Mother of drug addicted baby tells her story. So we all know there's no such thing as a drug addicted baby. And I thought of so many different ways this could be portrayed. But the media, it's a drug addicted baby. So I'd be curious in question and answers how what a better way to frame this would be. Thanks.
Thank you so much, Sarah, for sharing. That was a phenomenal presentation. We will now have a period of question and answer. So feel free to come off mute, state your name and ask Sarah a question. I know there's been a few in the chat. You're also welcome to chat in questions as well, and I'll read them to Sarah as well.
Hello.
Hello.
Hi, Sarah. My name is Lisa Becker. I'm an OBGYN hospitalist at Pres St. Luke's Medical Center, and I work on a high-risk OB service. You have a phenomenal talk, and it just speaks to my heart because what we're working on is things like not assuming that people who have been in recovery for 10 years still need a talk screen when they get to the floor, that kind of stuff. You know, like you said, that assumption, once an addict, always an addict, and we see it. My question to you is this available for our nurses, your talk to look at, or do you have other online resources?
Okay. Absolutely.
Awesome.
Please,
if you could send just that link or your email, I will offer this to the nurses. Thank you very much for.
Sounds good.
Yes.
Yeah, my email is on the last slide, so feel free.
Okay, thank you.
Yeah, and we will share this presentation, the recording, and Sarah's information following the presentation today as well.
Yeah, one resource I would point out right now is something called Shatterproof. It's an organization, an advocacy organization for people in recovery, and they have great materials that are for the public. You can reprint them on the stigma and substance use.
Looks like Heather in the chat has a question. It says, do you have some suggestions for training that clinicians, for clinicians, things they can share at staff meetings, making more people aware of this issue and inclusive language?
I do, and there's actually good research on this as well, that you know, the trainings are very impactful in terms of outcomes, and so I can share a few. Some of my favorites are actually coming from harm reduction programs, and I'll share a variety, but there are ones specifically for healthcare and then harm reduction models. And I was excited to see that one of the projects for one of the medical students this year is actually on language and stigma in medical school around substance use, and developed a whole, you know, educational model for it. So that was pretty cool.
Wow.
I have a question. You know, you were mentioning that your colleague said like, oh, I feel so bad because I've like realized that I said medication assisted treatment, and I know that I should be saying medication for addiction treatment or medication for opioid use disorder. So it made me think of, you know, I think it's hard because we all really want to do the right thing and use the right language, but it can be hard if, like, you know, you're in a culture where people are using sort of like the wrong language, and it's hard to sort of like correct someone on that without feeling like you're attacking them or like without making them feel bad. How would you recommend we do that? Like if we're with colleagues and someone uses a term that probably isn't really the best term, what's the best way to sort of gently suggest that we use a different term without making that person feel like attacked?
Yeah, this is the tricky one. And really modeling is the preferred method and often the most effective method. One of the other, you know, issues you bring up in this regard is So there's a big difference between how we as clinicians talk to patients and how patients might talk to us about their substance use. Or, for instance, in 12-step programs, it's widely accepted. But hello, I'm an addict, I'm an alcoholic. And that, is sort of reappropriating this terminology and empowering. Versus us talking to someone who's using substances or who is in recovery. And so it cloudies it even more when you're having a conversation with someone and they're referring to themselves as a junkie and you're saying a person with opioid use disorder. It can definitely get confusing. And I would say that I have this going on all the time, and it's, what do I want to start with? Medication assisted treatment is where the hill that I will die on. And I usually say things like, oh, I'm really starting to learn that, this has an impact. And I can do that, I think a lot more clearly than with a lot of these more nuanced models. And then certainly person first language is that's pretty widespread throughout the healthcare system. Some of these other terms, like I was saying about relapse, that's I think much more challenging. And so really starting with something that might be valuable to you, that you feel like you can really model is important, and starting there and presenting it as like, I'm just learning about this. This is cool.
We have a few more minutes for questions. If anyone else has questions for Sarah.
Does anyone want to try to reframe the mother of drug addicted baby? Kaylin?
Don't call on me first. I'm happy to, but I also was like biting my tongue. I think, Sarah, when you were, because I'm going to ask actually somebody else to take a shot at reframing this, because I know what I would say, but I think it's more helpful, like you're saying, if you kind of come from within, like what's the most comfortable phrasing or something for you. But I think the other thing that is so fascinating when patients are using terminology that we have said, that's kind of older terminology, we're going to focus to person first. What I typically say to patients is I'll say, hey, I hear you saying things, I hear you describing yourself as an addict or as a junkie, or, that you are dirty or something like that. And I'll just say, I don't want to take any words from you that feel meaningful, right? So if that feels meaningful to you, use whatever words you are comfortable with, but I will talk to you how I see you, which is a person with substance use. And so, and then I noticed that people kind of naturally taper off using using the terminology that they were using before. And so I think that's really, it's been very interesting to more kind of like purposefully address it instead of just like modeling, and just put it out there so that people know, like, this is the reason I'm using this terminology and these are the reasons I'm using these words. I haven't had anybody be like, oh, well, that's offensive, don't call me a person with substance use. You know what I mean? But I do agree. And I think especially in documentation, you're right. It's like, sometimes you read notes and you're like, geez Louise, like, this is not like, amateur novel hour. Like, you don't need to capture, like, I'm like, this person's suffering is dramatic enough. You don't need to like dramatize.
Exactly.
And I think that sometimes, if I put on my most compassionate and less cynical spirit, I think that comes out of a desire to capture the intensity of the suffering, but not knowing how to put into words the experience that they had taking care of that patient, either for the patient or for themselves. And so, yeah. Thank you, Amanda. Yep. Amanda put in an alternative.
I love these.
Right.
Yep. Yeah, that's a great point. And I can often, you know, the frustration from the healthcare professional is often evoked in the documentation, and the frustration is frequently, I know, not directed at the patient themselves. It's a systems level frustration, where there's, you know, chaos in the substance use, but the system is equally chaotic in wanting to help, which is what we all want to do. And you bring up a good point too about, you know, reclaiming language, you know, and stigmatizing labels is pretty common for social empowerment. And the, you know, the difference between very methodically using it within a 12-step construct versus a patient's talking about themselves because it's sort of just habit. Like there was no other way that they thought about it. And, you know, it's something I think we do at Cedar well is, you know, use that medical model, and people walking away saying, I had no idea that this is what was going on. So yeah, great points.
The other kind of addressing the question about like, how do we gently nudge our colleagues and other professionals when folks are using terminology. One thing we've introduced in the maternal mortality review committee is the oops and ouch kind of approach. And so I think, you know, in a clinical setting or in an office setting, you're on your floor, like maybe doing a little intro of like, hey, we're gonna, as we're working on changing our language around so many different domains, right? Of our patient's experience, of our patient's identifications. We want to make sure that we're using language that does no harm and hopefully is like healing language. And one of those ways that we can hold each other accountable is the oops and ouch, right? So if I say something that I'm like, oh, oops, own it. Like I did not mean to say it that way. And then if someone says something that you hear and you're like, oh, I would not have said that. Introducing the like, ouch. You know, I heard that and it hit me in a painful way, I think is a gentle and has been like fairly successful, I think, in our team in introducing the ability and the accountability to say something when we hear or say something ourselves that we wanted to do differently.
Yeah, it's got a playful aspect to it as well. Yeah.
Great. Well, thank you so much for sharing, Sarah. That was such a great presentation and so eye-opening. And we'll be sharing Sarah's contact information, the slides, and this recording after. It will be available on the website, and then we will also send it out via email. But if everyone could help me just say a warm thank you to Sarah. We really appreciate you coming today.
Thank you.
Yeah. So now we're going to move on to a presentation by the University Hospital team. I saw a few of you joined, and I am not sure if you had a slide presentation, but you are welcome to share your screen, and we can get started with that. This is going to be, oops, I'm seeing some questions in the chat. Elena, can you share the specific slide we can print? Yes, I will do that. I'll make it into a PDF with the language. So yeah, if any of the university team wants to share their screen, or if you're just sharing, that's also great.
Hey, Elena, it's Anne from university. I think Megan just sent it.
Oh, yeah, I can share my screen too. Hold on, let me find it.
Sorry.
No, you're fine. -3 points. I'm kidding. Okay. Let me share this. Can you all see that? Great. Yeah, so university team, take it away.
Great. You can go ahead and move to the next slide. I'm having some camera difficulties. I apologize. I'm Ann Baring. I'm the nurse manager of the mom baby unit, and Megan Hazel is one of our behavioral health social workers. And we're just going to share some of the things that we've been working on for the last year and a half. One of the big ones is our EPDS screening. The first project that we were trying to do was trying to move the time when the patients were actually receiving the screening. We did a whole lot of education with our staff, put it on some documentation that the nurses look at for report every day, and trying to move the mark to get it done hopefully within the first 12 hours that they arrive on the postpartum floor. The goal was just to have a longer period of time to be able to respond to any of the positive screens prior to going home. Megan, do you want to talk a little bit about that and how you think that it's going? Because you get most of the referrals.
For sure. So what we found was that we were learning about positive screens at the last minute, or maybe we weren't there. And so that's why we looked at the data to kind of show. So our goal was 12 hours. We ideally like the EPDS to be done 12 hours prior to discharge. And we have moved that process. And we've actually made our time increase. I'm not sure that we're quite to 12 hours on average, but that's been really helpful just because we were able to respond, which kind of leads to our second project that's alongside this, is making sure that not only do we screen, but that we're actually responding to the positive screen. So was on the EPDS would be if someone had a 10 or greater, or if question 10 was positive in any way. And so we've been working on, that's kind of the just starting currently, is looking at that and then trying to figure out how to better assess that. I believe that our response rate from the pathways team, so there's always providers that are and responding, but there isn't, but we actually want to make sure that our behavioral health team sees or works with the staff around each of those patients. And our goal is to do that with 100% of the patients. Well.
Right, and I can talk a little bit about the brand new project that we are working on. One of the things that we found out when some data was being pulled in a report for us is that the intervention score was quite low on any of the positive screens, and we found out that the staff was not documenting it in a consistent place. They were sometimes putting it in the flow sheet, sometimes in the notes. And in a report, you can only pull it from a flow sheet line, and there's more than one line that they can document on it also. So we actually have a process improvement team that is working on this to try and see where the best place to document it, and along with what Megan has already discussed about how do we get the people that are going to intervene to be notified in a timely manner. And that's the project. We just had our first big meeting on the process improvement last Friday. So lots of information coming down the pike on that. Can you go to the next slide, please? This is another thing that we have been working on, what Megan had referred to when we were trying to get everybody to do the EPDS screen in a timely manner, was to work on some scripting. We had rolled that out, gosh, almost a year ago, and due to a lot of turnover in staff, we realized that a lot of our success with that, we call it, got lost in translation. So we are just trying to re-engage on this project, putting it in our weekly Friday updates. We made little tiny signs that we're putting on all of the computers that the staff documents on, just to remind them of the importance of the EPDS screening and some scripting that they can do with the patient. And then our
next slide.
Our last slide. One of the things that we truly have been working on since we joined the CTCQC project is really getting every single patient to be treated absolutely the same from the time that they come in for prenatal care, deliver their baby, come to the postpartum floor, regardless of what service they're on. And that's been a very, very challenging thing. Part of the problem, because we're an academic medical center and a teaching hospital, our staff is constantly rotating. Every 6 weeks, we have a brand new group of residents. So it's just constantly reinforcing the teaching with every new group of, if somebody screens positive on the SBIRT, everybody has to be treated exactly the same way. We have run into a little bit of obstacle where people not wanting to breach trusting relationships, perhaps being on one unit for a couple of days and delivering their baby and coming up to the postpartum unit, and then we're implementing some measures that they've never heard of before, and it doesn't create a lot of trust in the environment that the rest of their care is going to be delivering. We're trying to think of some creative educational opportunities. We have met with the head of the residency program just to try and get things reinforced. And we've had a lot of turnover in our social work support, including the outpatient arena. So we're trying to work with the clinic to try and get some better continuity of care across the spectrum from the time that they come in for prenatal care throughout their entire pregnancy and when they arrive to have their baby. Megan, anything else you'd like to add?
No, I think that's it for the most part.
Great, that was awesome. That was exactly what we were hoping for. Does anyone have any questions for the university team? You can also chat it in. I can try to read it. Lisa says, I think residency is the perfect time to start instilling this training. I agree. And then they can take it to wherever they go next.
That's our hope.
I actually got on the agenda for the new group to be part of their orientation. So I'm pretty excited to get them when they're new coming into the organization.
Yeah. Mariah in the chat says, I'd love to learn more about the constant education. Mariah, I can connect you to the university team as well, and maybe you all can talk about it a little bit more.
Sure.
If you would like. Awesome. Yeah.
Yes, we're still developing. As it grows, we can happily share what we come up with, which works.
Yeah. Cheryl asks, what is the follow-up out to the community? Yeah.
Like with the patients, what's the follow-up like once they leave the hospital?
Yeah, I think so.
So a part of our program, so I'm a part of the perinatal pathways team, and our team focuses on both mental health and substance use. And part of our role is, sorry, there's a timer going off. Part of our role is to actually check in not only once they're in the hospital, but also as they leave the hospital to make sure that people aren't lost, they don't drop off, or you know, if what we set them up with doesn't work, our hope is to like have that conversation via phone and get them reconnected. If patients are kind of not ready to do that, we do that piece. And then we also try really hard to have good connections with our outpatient social workers and connections to the other clinics, such as Stride and things like that, so that we're also doing as many warm handoffs as we can to like make sure that patients have that connection, so that they're leaving and someone knows sort of what the plan is.
She also says she loves the warm handoffs connections.
One of the other projects that we recently finally got going is that we are now able to hand out Narcan at discharge. That was quite a lengthy process for us to do it correctly and keep in line with all the pharmacy regulations, but we are participating in the Colorado naloxone project and with the OB grant. So we've successfully handed out 2 doses in the last week, and pretty excited to be doing that now.
That's awesome. Great. Well, thank you all for sharing. That was really helpful, and we love hearing your progress. It really brings some depth to just like kind of the face value of what we're presenting. So thank you all for sharing that.
Thanks, Elena.
Yeah, of course. So we are 5 minutes from the end, and we would just love if you could take this 5 minutes to fill out our evaluation poll. It shouldn't take very long. I'll pop it up on the screen. If you could just take a few minutes to answer that, that would be lovely. And thank you all for joining us today. We love seeing your faces, and we will all see you at the May coaching call.
Also, while you're filling that out and before you hop off, so data collection started April 1st. If you have any questions about that, please let us know. We're happy to provide as much support as you need to help you make sure you're gathering the right things and documenting it the right way. So please reach out if there's any support we can provide on data collection.
Have a great day, everyone.
Thank you.